afternoon, one and all. I am Dr. Pinkal Shiroya, and I am going to present on long-term outcomes of deep anterior lamellar keratoplasty in pediatric keratoconus. As we all are aware that pediatric keratoconus is aggressive and rapidly progressive in nature, and the keratoplasty in pediatric keratoconus is always challenging because of lower scleral rigidity, general anesthesia, suture-related complication, graft rejection due to stronger immune system of pediatric patients. Deep anterior lamellar keratoplasty was the preferred procedure in our group. Lacuna in the literature is limited number of subjects, includes wide range group of age. Outcome includes several other indications, not specifically keratoconus. The aim of my study is to analyze the long-term outcome of deep anterior lamellar keratoplasty in pediatric keratoconus. It is a retrospective study of all the keratoconus patients less than 18 years coming to the Cornea clinic of Arvind Eye Hospital, Coimbatore in a time span of February 2008 to December 2019. All the patients underwent pre-op evaluation, slit lamp examination, visual acuity and refraction and topography. The surgical technique used in our study was big bubble technique, and 0.25 mm oversized button was sutured with 10 nylon. As a post-op regimen, topical prednisolone was given in tapering doses initially and then was later shifted to loteprednol and cyclosporin. This is how we are going to look into our results. 221 eyes of 185 patients underwent DALK. Mean age group was 6 to 18 years. In our study, 71% male predominance was seen more and left eye was operated more. The mean follow-up was from a range of 6 to 130 months. The most common comorbidity associated in our study was vernal keratoconjunctivitis. 39.3% of the patient had. Corneal apical scars were found in 6.65% of the patient, and deep scars in ASOCT was found in 1.3% of the patient. On comparing the visual outcome, the mean uncorrected visual acuity showed the improvement of 0.51 logMAR unit, and the best corrected visual acuity showed the improvement of 0.48 logMAR unit. On coming to refraction, the spherical component showed the tremendous improvement of 5.37 diopter, and cylindrical component showed the improvement of 2.38 diopter. Similar results were found in keratometry. Keratometry showed the improvement of 9.56 and SIMK showed the improvement of 3.35. On coming to the final vision, 80% of the patient had visual acuity better than 612. If we compare it with the other study like Arora et al., which showed the improvement of 45%, Patel et al., which showed the improvement of 86%, and Fizi et al., which showed the improvement of 84%. Surgical techniques, big bubble was successfully achieved in 66% of the patients, and in whom where we could not achieve big bubble, either patients were dealt with hydrodissection or manual dissection. If we compare the big bubble achievement with the other studies, Fizi et al. Showed 75%, Nuxchan et al. Showed 77%, and Arora et al. Showed 80%. But all this study included adult patients as well. On coming to the intra-op complication, DM perforation was noted in 15.39% of the patient, and 20 patients which had DM perforation had double AC and which were treated with rebubbling. On coming to post-op complication, the most common post-op complication is glaucoma. 14.9% of the patient had glaucoma. 30 patients were treated with anti-glaucoma medication. 2 patients were treated with laser trabeculoplasty, and one patient was treated with TRAP. Second most common post-op complication is cataract. 5.7% of the patient had cataract in our study. The commonest type of cataract found was posterior subcapsular cataract, and the 5 patients which underwent rebubbling had cataract as their post-op complication. The third most important post-op complication was delayed epithelial healing, which we saw in 20% of the patient, and 2% of the patient had non-healing epithelial defect and were treated with Botox. If we talk about the suture-related things, suture removal was initiated by 7 months in our study and was completed by 29 months. And 49 cases underwent replacement in and around 3 months. Graft-related complications, 13.12% of the patient had vascularization, which includes superficial and deep. 9.5% of the patient had infection, that is Streptococcus pneumoniae. and 6.67% of the patient had graft rejection, and it was treated with topical steroids. If we compare the fellow eye management of all 221 patients of eyes who underwent DALC, other eye was treated with C3R, which was treated with number was 48.87%. DALC was for 10.86% where patients were treated with DALC, and 2.71% of the patients were treated with PKP. If we compare the VKC and non-VKC group, we could find that in VKC group there was a delayed epithelial healing, vascularization was seen more, and graft rejection was seen more as compared to non-VKC group. These are the review of my literature, and hence at the end I would like to conclude my study. DALC is the most effective technique for pediatric keratoconus with good visual recovery and graft survival. DALC can be associated with unique complications like DM perforation and double anterior chamber, and Werner keratoconjunctivitis needs to be addressed to avoid the complications in pediatric keratoconus. These are my references. Thank you.
So did you observe that the growth of the keratoconus has stopped before doing DALC?
Pardon me?
See, in progressive keratoconus, if you do DALC, then the chances of complications are more. So in pediatric groups, which level of keratoconus, which grade of keratoconus you took for
mostly
surgery?
we chose the advanced keratoconus patients for doing the DALC surgery, because if the patients, we gave them options of C3R, but if they were not fitting it into the the C3R category, then we were giving them, they had to undergo the DALC procedure.
Patients in whom you had DM perforation, were those cases converted to PK, or
Few patients we converted to PK, like 6 patients we converted to PK, but in those where only tiny DM perforation was there, and we tried for rebubbling or
was the incidence of cataract more in patients who had DM perforation intra-op?
Like 5 patients we saw, 5 patients had DM perforation, had cataract as the post-op complication.
What could have been the cause for glaucoma, secondary glaucoma in these cases?
Mainly because of pigment dispersion, the trabecular meshwork would have blocked, and that can be one of the cause for the glaucoma in the patients.
What is the protocol you followed for VKC patients? I mean, how did you treat VKC in these patients before taking them for DALC or PK or whatever?
If the patient had VKC, active VKC, we were treating them with the steroids or any immunosuppressants.
Topical?
Topical, sir.
Okay.
Yeah. And we were, until and unless if we are taking off the steroids and still the VKC is like inactive, then only we will transfer that patient to
How long you say?
So minimum for one and a half month we did.
1.5 month of inactivity of VKC, that's what you mean to say.
Yeah.
And you mentioned that some of your VKC patients, more of your VKC patients had vascularization.
Yes,
so when they developed vascularization, did it change your line of management, or did you add some systemic immunosuppression, immunomodulators, maybe cyclosporin or anything? Was it added?
Yeah, we added steroids, sir, for oral Visalon steroids according to
that is for temporary purpose, but once the vascularization is initiated, so did you think of adding any immunomodulator like oral cyclosporin, or was not added in this study?
No, sir, in our study we did not add any oral immunosuppressants. Either we were giving them topical immunosuppressants like
no, I am asking, once you have suppressed the VKC with topical medications, then you did DALC, and then you are noticing that now the deep vascularization is coming up, right?
Yeah, sir.
Now, do you think that we need to add systemic immunosuppression, or we need to continue on the drops which we have been giving before?
So, like in our study, we did not start a topical
Okay.
oral immunosuppressant for the patients.
You did not start.
You did not
Okay.
start.
And one more thing, what were the common clinical presentation in cases with rejection?
So, like stromal edema will be there,
Okay.
sir.
Did you notice any interface fluid in these patients?
Interface vascular.
Interface fluid?
Interface fluid, no.
No.
No,
Okay. In rejection cases, did
No,
you look
no.
for it?
No, sir, we did not like.
Yeah, you didn't look for
we
it,
did
right?
not look for
Yeah.
it.
So if you study these patients of DALC with rejection in pediatric age group, most of them have interface fluid, and
Okay.
sometimes it is vascularization with interface fluid is sometimes indication of rejection, which you might consider just as a vascularization, which you mentioned as vascularization. So they might be having some interface fluid and they might be at early stage of rejection. So that's why I suggested that in case you notice the vascularization and if you look at the interface properly or earliest sign of devascularization, I think you should shift to systemic immunosuppression, at least in patients with VKC, at least systemic immunomodulator like cyclosporin or anything.